Hi, thank you all for being here and for having me. And I hope this will be a pretty interactive session, at least at a few different points, where I can share with you some of the things we've learned about this subject, but also hopefully we can all learn from each other. So Claire already went over, so just a reminder to mute. I don't have any conflicts of interest to disclose. This is a topic where I think it's good to recognize that we all have positionality. We have our specific areas of expertise and our experience that influences how we see things, and we have areas of privilege, blind spots. So what we're going to do, we're going to reflect a little bit on our own experiences, and I'll start with the story that really got me thinking about this topic with regard to how you've seen this taught in clinical practice at the bedside, either as a learner or an educator. I'll talk a little bit about the gap between preclinical and clinical, why we may have great preclinical courses and yet still hear from our students that they're not seeing those lessons applied at the bedside. And I'll talk about some of the challenges and barriers that clinician educators face when they're teaching about social and structural determinants of health in clinical spaces. And then we'll talk about some strategies for overcoming these challenges, specifically coming from a qualitative study that we did with our faculty. And we'll end with some vignettes, and so hopefully some great discussion of how we might apply those strategies to those situations. So this is the case. This has been de-identified, and so some of the details have been changed. But this is the case that really got me thinking about whether we teach well about social determinants of health at the bedside and how we do it, and how often we might be providing good care that thinks about these things, but maybe not making our efforts visible for students. So Caden was one of my patients, a 4-year-old boy who had had AML at age 2 and undergone a bone marrow transplant. And he had a lot of chronic medical problems post-transplant. He had a lot of specialists at 2 different hospitals, as well as a family practitioner for his routine care. And he had some developmental delays, especially in expressive language and fine motor skills. So on the day I really started thinking about this, he was scheduled for a routine follow-up visit with me. He had a very standard chief complaint line, not very descriptive, 8-week follow-up, exam, labs, needs echo. And we had a 4th-year medical student who asked if she could get started on the visit and what she might need to know in advance. And I paused at that point, thinking about some of the things that I thought about before going into the room when I saw this patient. So Caden's parents had one of the more volatile relationships that I had ever seen in clinic. And they sometimes seem to use our space to assert who might be the better parent. I will say I would often go through reminding myself before I went to visits that they both really loved their son. And even though this was often not the easiest experience for me to navigate, it did sort of show how committed they really were to his well-being. But each of them had called CPS on the other in the past, and they sometimes tried to grab the nearest available healthcare provider to help back up those accusations, even though there was really no concerns for abuse that had ever been witnessed in the healthcare system. And the last thing I sometimes thought about before going in the room was that hygiene was often poor for the entire family. And I thought, what do I tell this student? I'm happy for her to go see this patient. She's a 4th year. She's doing an acting internship. I think this is a kind of a typical visit for us in some ways, follow-up care years after transplant, understanding late effects. There's lots of great medical teaching points. But what do I tell her about the social issues? And how am I going to say it in a way that doesn't quickly, but that doesn't just bias her against this family or send her in thinking, oh my God, this is going to be a horrible visit, or lead her to say, oh, okay, maybe I'll wait for the next patient. This sounds too complicated. What do I tell her? Because there were a lot of other things aside from that conversation that I always had with myself before I saw this family, this sort of deep breath, remembering, yes, they sometimes seem angry, but they're devoted to their child. And anger had really gotten them pretty far in life. Being angry with not such a great lot had been how they survived. So these are some of the other things that I knew that weren't necessarily easy to find in the chart or obvious to the student, but that I knew about this situation. So the parents were relatively young. They hadn't been married and they had an on-again, off-again relationship. They had an older child, and Caden's dad also had another child from another former relationship who was younger. He split his time between two households, both in one in a really rural area and one in a relatively small town. So they lived quite some distance from the hospital, and just getting to us was sometimes difficult. And Caden's mom was living with her grandfather and her step grandmother and her teenage sister, while Caden's dad, Carlos, was living with his former fiance and their daughter some of the time. They weren't always in the household. And it depended, he went back and forth depending on who had work at a given time. And as I was thinking about that, I thought a little bit further about things in my long relationship with this family that I had come to know about their pretty complicated pasts. So they both of them were separated from their families for different reasons related to physical abuse and incarceration in Caden's mom's family, related to deportation in his dad's family. There were some concerns for substance use. They had a high school education, but not much more past that. And his mom had been trying to work on community college classes when he got sick, but had then really taken a break to be a full-time parent. And how these things were received by my colleagues varied a lot. So I also had a lot of occasions to witness some of the bias they experienced from the healthcare system because of their history, or sometimes there was some judgment against the mom for not wanting to work, for wanting to be home with her sick child. Sometimes that we saw judgment against parents for the opposite reason, where we had parents who wanted to go back to work. But I was thinking about all of this and thinking, how do I teach? I am thinking about these things when I go into this visit, and to varying degrees, considering them in my plan of care. I'm following up with the family about some of these different resource issues and trying to make sure they're connected with our social worker. But what do I tell the student? How do I teach her to handle cases like this? How do I talk about this with her and make it visible? And so that's where this project really begins. How do we, when we're trying to provide good care that is informed by social determinants of health, structural determinants of health, that is trauma informed, how do we make that visible for students? So I'd like at this point to ask you all to think a little bit about a time when you were taught about this at the bedside, when you thought about these things as a learner, if you ever have. And if you'd like in the chat to share a little bit about that experience, what happened, what you learned, whether it was a positive or a negative lesson, whether you think it was intentional or part of the hidden curriculum, or what you took away from the experience, or all of that. Or if you've never had any teaching like this at the bedside, please share that as well. I'd be curious to know who has and who hasn't. So we've got one, I've never really had any teaching related to this. Anybody else? M&M conference presentations included a thorough explanation of social influencers. Yeah, that's a great one. So that's one we've been working on recently that I had not consistently seen before, but including it in our pediatric M&Ms. A lot of times it was the whispered discussion at bedside before entering the patient's room. Yeah, I think that's an interesting kind of ability where we say things in sort of a hush hush way, but maybe not with the intentionality of what do we want people to take away from this. We've got another one. I always learned to draw a family tree, which is especially useful in horizontal families, and the tree was in the chart. That's a really great idea to really show the relationships, because I think often in my training, we weren't even always consistently seeing the people in the room asked to identify themselves in their relationship to the child. And sometimes there seemed to be a little bit of fear of, am I going to come across as judgmental if I ask, who are you and how are you related to this child? But in many families, it's not obvious, or we may make assumptions that the two people in the room are the parents that prove not to be true. Feel free to keep sharing your learner experiences, but I'd like to turn now to, as an educator, how are you teaching about this right now? What are you thinking about when you're rounding, when you're in clinic? And again, feel free to share in the chat how you approach this, What do you try to teach learners? What do you think they take away from the experience? And what do you take away from the experience of teaching about social determinants of health at the bedside? It seems easier for learners to describe poverty and housing as patient social realities. They have a tougher time articulating issues of racism, oppression, and hate crimes, police abuse. Yeah, I would agree with that. With our pediatric residents in the spring, when COVID started, we started a weekly ethics series. And of course, in June, around George Floyd's murder, we had a lot more discussions of racism than we had had previously. But what came out is very few of our residents had experiences where they explicitly discussed experiences of racism with patients and families, or asked about their concerns about policing, whether in the community or in schools. Any other experiences? So another one from Simone. I spend a lot of time asking why. Why do you think they do that? Why do you think that happened? What might be contributing to that? I think those are great, really great questions. And with this, with the family, I started with a lot of what I learned from them was asking those why questions and thinking about, when I find them difficult to work with, why is that? And why are they interacting with the healthcare system that way? And coming to recognize that it had really been productive for them to interact in a more argumentative way. So there's some comments about expectations, that when they present the case, something about the family and how they live together will be included. Walking through medical decision making to include details related to access to transportation, to housing. Those are great. Okay, so why is there a gap? So there's quite a bit, and I think many of you who have expertise in this area will be familiar with these, of deliberate and formal efforts to teach about social and structural determinants of health, but they're much more often in the literature and in our anecdotal experiences and talking to faculty at other schools in the classroom rather than in the clinical years. And part of that clinical curriculum in general is more informal and less structured. But there's also a sort of lack of guidance about how this should be done during the clinical years of training, especially the third and fourth year of medical school. But when I talk to people in other professional programs, this cuts across not just medicine, but the health professions broadly. We do a better job with intentional teaching when we're in the classroom, and not as good of a job in the clinical space. There are some expert guidelines on teaching social determinants of health that cut across preclinical and clinical. So I just wanted to call attention to this study, and to say that it's not that there's no literature on this, but it does seem to be much less common in the clinical years. And one of the interesting things that came out is this idea that SDH should constitute about a third of the total curriculum and be taught continuously throughout the curriculum. These are really just for reference. I won't go through them line by line, but that Delphi study highlighted some of the key relevant knowledge points, which some of you have brought up in the chat. The relevant skills, the majority of which are clinical skills. Some of them are public health or policy level skills, but most of them are things that we can teach in the clinic, teach in the hospital, and assess our learners on. And then attitudes, which cuts across the preclinical and clinical curriculum as well. So we were interested in this question, and I started from the assumption that many clinicians are good at this, which is not to say that there isn't a great deal more room for improving how we provide clinical care with regard to SDH, but that there are already clinicians and faculty out there who are very well informed, who have really set up their clinics around this idea, around providing socially aware care and structurally competent care. So we started from that point and said, well, what do these people who are already experts, what do these faculty know about teaching at the bedside, and what can we learn from them and perhaps adapt into guidelines that we can share with other faculty who don't self-identify as experts? So over the past 2 years, we conducted a qualitative study using in-depth semi-structured interviews with clinician educators and then focus groups with our third and fourth year medical students. So the clinician educators were nominated either by their or students as being expert clinicians in this area, and we used a snowball recruitment method. So every time we interviewed someone, we asked them to nominate someone else who they also thought of as an expert. And then we transcribed the interviews, coded them iteratively with 4 study team members, and had pretty good interrelator reliability. So the first thing that came out, although we really designed our focus group and interview guides to focus on the positive, to ask about the facilitators and the techniques and tools. But of course, one of the things that came out anyway was the barriers. So barriers to bedside teaching, and I think this will surprise very few people working in the clinical world today, time constraints, that there's not enough time to teach this in the clinic. The incentive structure, that students are not rewarded for mastering these skills. And some of us hope perhaps that will change as we shift away from a graded step one and some of the other changes that are happening in medical education now. There were concerns about the documentation requirements and some of this again has changed over the landscape has changed a little bit with regard to student notes, but we found a lot of faculty were still in the default of saying student notes don't count for anything, therefore I need to design my clinic to account for that and not have my students doing much of this because I'm just going to have to repeat all their work, which goes back to the time constraints. They identified a lack of training, that they weren't trained in how to teach about SDH at the bedside, and then a lack of resources, so not having support to teach or assess students in this area. So here's a few of the quotes that really represent some of the concerns of the faculty in our study. So one pediatrician who directed a clinic for medically complex children said, "I don't feel that I'm particularly good at this, unfortunately, just because of the time constraints. So usually because I'm needing to stay on schedule and document in time, they're usually fly on the wall shadowing me. I think I could probably involve students more than I am, and it's just purely a function of how I have to stay on schedule." Another participant was an orthopedic surgeon directing an MLP, who said, "I think it's just a matter of priorities and resources. So everyone has to come out and recognize this issue as a significant issue, but I don't think we've yet had the right resources applied. And if we did, if there were grant funding, if there were research funding, if there were medical school initiatives that prioritize these kinds of things, and if they were backed by resources." So really saying more resources that incentivize us to do this would lead to us doing this more. This is the best part. So these are the best practices that faculty came up with. And they grouped into 4 themes: modeling, debriefing, chart review, hands-on experiences, and frameworks for teaching. So the idea behind modeling was really that students learn from watching us do this well. So this was from a MedPeds physician who directs our refugee health clinic. And she said, "I have students who work with me in refugee clinic. And while I'm probably not the best model of efficiency, I don't open the computer in the room with non-English speakers unless I'm looking at some data or trying to show them something on the screen, because they can't type and put in orders while I'm trying to read someone's body language and watch how they interact with an interpreter." So I think students get that from modeling. And then once they sort of see how it's done, then they go in with their own patients. That for me, for her, those are the students who return for longer electives, while those for just a brief period just see the modeling, but don't necessarily get to demonstrate their skills. So debriefing, several different models of debriefing came up. So this is one of our internal medicine docs. So sometimes when there's a longer conversation, I basically just ask, so tell me about the interaction you just witnessed, and try to keep it as open-ended as possible. And then hopefully they'll see what I want them to see. And usually I don't have to do much guiding because it's very clear what I'm doing there. So some of the debriefing models that faculty mentioned included using a 3 or a 4 culture model to think about how the culture of the institution and of Western medicine might interact with the patient's culture, with their family culture, which may be different, particularly when we're seeing children who are 1st or 2nd generation, and then the provider's culture. So what sorts of values and beliefs they're bringing to the encounter. So some of the faculty use this model for debriefing after the encounter to talk about what did you see happen in this framework, and how do you think it affected the interaction? Others brought up this model of the 5 R's, so reflection, respect, regard, relevance, and resiliency, saying that they use this as a framework for debriefing students after the encounter, asking them, what did I learn from the encounter? Did I treat everyone involved in that encounter respectfully? Did unconscious bias affect this interaction? And if so, how? How was cultural humility relevant to this interaction? And then how was my personal resiliency affected by this interaction? Hands-on experiences. So several of our faculty brought up that idea that it's not just that we have to get beyond modeling to the point where students get to actually experience asking families about these issues, about SDH, and then developing a plan that takes into account their SDH. So these were some of the models that different faculty used with students to help get at taking a history that incorporates social determinants of health or structural competency or cultural humility. And then some had planned clinical experiences, so biopsychosocial rounds, using family-centered rounds. Some rotations had intentional shadowing with other members of the healthcare team, then getting 360-degree feedback of the student as part of the evaluation. And then some were using a health equity rounds model. I just wanted to highlight from the models that learners can use for history taking. Some of you may have seen this from an article a few years ago, but the structural vulnerability tool is a particularly comprehensive one that gets at several different domains. So financial security, residence, risk environments, food access, social network, legal status, education, and then discrimination, which I've still found with my learners is the one we're least likely to ask about. So asking patients, have you experienced discrimination based on any of these things, but then also asking ourselves, could the interactional style of this patient alienate some service providers? Could it elicit stigma? Are there aspects of the patient's experience, a patient's appearance, ethnicity that may affect how they receive their care, or how service providers treat them? Might they elicit distrust? And many of these things resonated with me because of that first case I talked about, because that family's interactional style, that family's hygiene, in many ways were very likely to provoke bias. And it really has gotten me thinking about how do we talk to learners about that? How do we prepare them for that before they go into a room? And how do we reflect on it afterwards? And then finally, faculty really liked having concrete frameworks for teaching. And this is one of the best ones that came up. It's called Time Effective Strategies for Teaching, published back in 2010. And it starts with identifying the learner's need or gap in knowledge, skills, and attitudes, and then targeting teaching to those needs. This is the matrix of questions. So if you identify a knowledge gap, these are the questions that you can ask the learner. So for instance, tell me about asking them to reflect about the last time they took care of a patient with this particular problem. And these can be steered towards SDH, towards structural competency questions. There's questions for skills, questions for attitude barriers, again, getting at bias and discrimination. And then adverse circumstances. So looking at how we prioritize problems, patients' problems, and how the structure of our hospital or clinic might make it challenging to care for patients with certain issues. Some of the other tips for teaching in rounds and in clinic that came out of our study. So encouraging learners to use the appropriate vocabulary and defining key terms when they don't know them. Remembering to reflect on the positive aspects of social determinants of health too. So for instance, when a family has a especially supportive family or community, even though they may not have a lot of education or wealth or other privileges. So we often don't call attention to that. What many faculty and many of our students brought up is that we talk about social determinants of health as a negative thing, when in fact it can be negative, positive, or neutral. And then we very rarely discuss how privilege might be benefiting certain patients, how their status might be getting them access to resources or to care that other patients don't have. Creating space in our usual teaching activities. For example, if we ask students to bring articles relevant, which we often do, to bring an article relevant to a current patient to share with the team, we might suggest that it be an article that addresses health disparities. If we ask them to present an M&M, as it came up earlier in the chat, or another conference, making sure that some of the cases we use are notable for their cultural or structural features rather than just being interesting because of the diagnosis. And the health equity rounds model published last year is a really helpful one. Relating disparities to basic sciences when appropriate. So at my school and others, I imagine there's quite a push to try to integrate the basic sciences into the clinical years and make sure that students are able to connect what they're seeing on rounds back to what they learned earlier in their training. But we can do that with health disparities and with social determinants as well. We can talk about the biology of stress and allostatic load. We can talk about other topics. We can talk about, there's been some great articles recently looking at how various clinical algorithms like the GFR correction for race may actually perpetuate disparities. So we can talk about the science of that on rounds. And then incorporating a history lesson into rounds or clinic when appropriate. How did these tools evolve? How might bias have contributed to how they were used in the past? Why is a particular department or clinic or hospital organized the way it is? And how did the history of racism contribute to those things? So those are all things that we can bring up to better integrate SDH into our clinical teaching. Okay, so in the last half of our time, and I'll try to leave about 10 minutes for questions at the end, I wanted to show you some of the cases that we initially developed for our students, all based on real cases. And since we've been adapting them to actually teach faculty to talk about, not about how you would address the case from a clinical or an ethical standpoint, but how would you address this situation as an educator? So case number one, and I'll ask you guys to just chime in the chat when we get to the questions. And there's also some other resources in the chat. Samuel Entz is a 14-year-old boy, and so names and details have all been changed on these, from a Mennonite community who has a pineal germinoma, highly curable type of brain tumor. He recently completed the recommended 4 cycles of chemotherapy and is scheduled to begin 6 weeks of radiation to consolidate his remission, after which he'll be done with treatment. This combined treatment is associated with a 95% chance of cure. However, his parents follow up to discuss the treatment, and then they state that they've actually decided against radiation. They've concluded that the risks of the radiation therapy at this point outweigh the 50% risk of relapse, because they know and understand from their conversations with their oncologists that most relapses are still curable with salvage treatment. In general, their preference is for natural treatments in how they described it, such as herbal supplements and vitamins. They see a naturopathic practitioner who's actually the one who originally referred them for the CT scan that led to the tumor being diagnosed. Although they have some financial concerns, since like both Amish and many Mennonite, they don't accept government assistance. They state that financial assistance wouldn't change their decision. They also indicate that they believe a higher power is ultimately in control of their son's fate, and regardless of their decision, whatever happens is God's will. The radiation oncologist asked to speak with them once more before they leave the clinic. They maintain their decision and ask him to pray for them. And he replies, "If I pray, I'll pray for you to accept the radiation." So assume you're a member of the team in this situation. There was a pediatric resident present, a radiation oncology resident, and a 4th-year medical student. What are the key points that you would like them to learn from the experience? Thinking about this case, what would you want a learner to take away? There's lots of possible answers. So when I think about this case, there's lessons, particularly for the medical student and, well, actually for the medical student and the resident, about the limits of decision-making authority when parents can make decisions, when teenagers can make decisions. So we have a young teen who probably doesn't qualify as a mature minor, but I might want them to think about some of those issues. From the chat, from Christiana, do we as the medical community feel comfortable that we understood all the reasons why the family made this choice? Yeah, so that's a great teaching point. How do we know, and I deal with this a lot as an ethicist, how do we know when we've fully explored the dilemma and have all the information that we need to feel comfortable not saying anything, either not intervening or intervening if this is a case that we're going to take to Child Protective Services for medical neglect. But if we're not, how do we feel that we've completed the conversation with the family, that we understand all their reasons and that we feel comfortable that they have all the information they need to make an informed choice. So that's a great learning point. Anything else? Might want them to be thinking about when sort of the limits of parental decision making, of adolescent decision making, about how religion and culture interact in that space. I also would probably want to say something about what the radiation oncologist said at the end, about when do we bring up when a family asks us to pray for them, what is the right response? And not that there's any one right response, but how do we respond to that? How might they respond to it? Are they okay with what the radiation oncologist said, saying, I'll pray, but I'm going to pray for you to accept radiation? What are the tools or techniques that you might use? How would you teach about this? And we've gone through some of the ones that our faculty thought were useful in terms of debriefing and reflection afterwards. But are there other tools or techniques that you might use either during or after this encounter? And Tabitha said, I was just going to bring that up. I would say it's inappropriate to respond the way he did. Yeah, it's not very culturally competent. It's certainly what the textbook would teach. And I think one of the interesting things that in how this encounter eventually went down, the family did come back the next day and had prayed and changed their mind, and decided to accept radiation and continue to have, and this is one of the reasons I often use this case with students, because it didn't come across to me in the moment as culturally humble at all. It's not what I would ever encourage a student to say to a family. And yet for this family, it actually really resonated. And it really worked for them, and it maintained their relationship with the radiation oncologist in a really interesting way.
Hi, this is Christiana. If it's okay, I'm going to unmute because it's a
Yeah.
little faster than typing.
Oh, yeah, absolutely.
I was going to say, I think the idea is to make a connection with the family, to understand that both sides want the best for this child, and that they're interpreting some of the facts that are immutable in different ways. And I think that was at the crux of what the radiation oncologist was trying to say, but maybe the delivery was, initially, from our standpoint, perceived as insensitive.
Yeah, absolutely. I mean, it definitely in the moment was perceived by many members of the healthcare team as insensitive, and actually perhaps perceived as more insensitive by the team than by the family. There's another comment about you model using the phrase, tell me more about that when speaking with patients who have attitudes different from the doctors. Yeah. Does anyone have thoughts on what kinds of encounters they involved? Someone asked her, did they actually pray and get another answer? Yeah, I mean, I think it's hard to know with something as personal as someone's prayer experience. But I think it's sort of intersected. They prayed, he prayed, everyone prayed for the best outcome, and ultimately that came together in the family deciding to go ahead with radiation. But so hard to know exactly what happened. But for me, it's always highlighted how we do our best to say the right thing in the right moment, and sometimes we say the wrong thing, and it's not the end of the world, but we learn from it and move on. And in this case, what looked like the wrong thing really didn't damage the relationship with the family in the way that I was concerned. And I hope from that learners do not learn to go and tell families sort of such prescriptive statements, but that they learn that it's okay to try to do their best and to reflect on that and do better the next time. Sorry, my son's coming. No, not right now, Finn. Any other thoughts? Are there encounters? These are pretty complex encounters. Does anyone have thoughts about when they include students or learners or don't include students and learners? Are situations like these, and I can go on to the next one for another example, are you including your learners in these cases? Are they involved from beginning to end? Or are these the cases that we tend to say, oh no, wait, see a less complex patient.
This is Christiana again. I'm a pediatric oncologist at UIC, so I have this this type of situation somewhat often. I think if it's a patient that I've had a relationship for a period of time, and there's a point at which this is a potentially charged encounter, I would prefer to do it without a learner in the room, more so to preserve the ability for the family to sort of feel free in their emotional responses, and not try to kind of have that social presence when you know, a new person is there. Or maybe I'm projecting, but that's sort of the thought behind it.
Yeah, no, I agree that it's something we need to think about and not invite a huge audience into a room, but also, so I probably should have added in the case, not every single person of the learners who were present, they weren't all in the room for the conversation in the family. They were all around and knew what was going on. So some of the questions we were asking ourselves is, how do we bring them into the learning experience, if not into the exam room? And when is it appropriate and really necessary to have them be in the exam room if the family's okay with that? But even if they're not, how do we make sure they're still taking away some useful lessons for how they care for their own patients in the future?
Yeah, I agree. I think it's a tough one. You want to respect the family's emotional journey, especially in these conversations that can lead to a significant change in their therapy. But at the same time, yes, you want to give the opportunity to your learners to, you know, model or take a certain number of lessons from these interactions. So I don't know if I have a sort of a good way through this.
Okay, I'll go on to the next one. They're not all oncology cases, but these first two are. So Elisa James is a 19-year-old young woman with recurrent lymphoma. She was initially diagnosed at 17 and completed only part of the recommended therapy before deciding to stop because she was feeling interfered with her work. She was found to have relapsed when she presented with symptoms of COVID. She's been scheduled for chemotherapy in the clinic's infusion center on a Friday, but she misses the appointment because she has to care for her nieces and nephews, and her sister is several hours late to pick them up. The infusion is rescheduled for Saturday morning, which is not standard for the practice. However, Elisa doesn't arrive at her scheduled appointment time on Saturday and doesn't answer her phone. The physician on call and the social worker speak about what to do, and the social worker keeps trying to contact her. Eventually, she gets in touch with Elisa, and after a fight with her brother-in-law, she had spent the night in her car, which is something she does pretty regularly as she bounces between friends and family's apartments. So she doesn't have a very stable housing situation. And exhausted by the time she actually fell asleep in her car, she overslept in the morning and she gets to the hospital 2 hours late. So if you're a member of team in this situation, so a pediatric resident, a child life intern, and a social work intern are present. And I did want to highlight that in many of the situations, there's interprofessional learners who may have different points of view and different things to learn and share from the experience. What are the key points that you would want a learner to get out of this experience? And I like the question in the chat, can the learner screw things up in a way that I cannot remediate? If so, don't let them in. That's really good advice. So a patient with sort of housing instability, who's arriving very late for her appointment, which was already scheduled at an off time to try to accommodate her socially complex situation. What would we want a student or a trainee to get out of this? And how might you teach about it? How difficult it must be in her shoes. So empathy as a teaching point. And I think particularly in any situation where students are very, in my experience, are very sensitive to attending and supervisor frustration. to recognizing when we're feeling impatient or feeling that the patient's behavior is burdening us. And so taking that time to reflect on our own compassion and empathy and to talk about that with learners is really important. Any other thoughts? I think of this one as also one where it's a good time to talk about what other resources are available and how we work with our colleagues interprofessionally, because not every provider is going to be the person who solves all these problems for the patient. If any of them, or who works on that. But we have other resources available. We have social workers, we have other members of our psychosocial team, and we can work together to provide the best care. So I think there's some good opportunities for teaching about interprofessional communication and teamwork. It also might be a good opportunity for a learner to take a more thorough history and find out what other resources she might, if that hasn't been done already, what other resources might be useful to her. Okay, I'm going to go on to the next one, but not oncology one, so we can change tactics a little bit. So Nia Jones is a 22-year-old young woman who's 33 weeks pregnant and experiencing symptoms of preterm labor. She was recently released from jail on drug charges. She denies the accusations, but does believe the father of her child was selling drugs from their apartment. They have now separated, and she's anxious that he'll be released soon too. She has a history of intimate partner violence. In the room, she tells medical students on the OBGYN clerkship that she's not comfortable with him in the room during her exam. And the student is a man and is Black, which comes up, the student brings up later. But you are biased. So if you're a member of the team, in addition to the third year medical student who was asked to leave, there's also a nurse midwifery student who's present. So what are the points that, what do you think the learning points are in this encounter? Thoughts? I think this is challenging because the concern for bias is real. I mean, certainly we see disproportionately that male students are asked to leave the room on obstetrics and gynecology interactions, understandably. We also see a lot of concerns about bias towards students who are African American being asked to not participate in care, not necessarily on OB, but maybe more generally. But at the same time, we have a patient who is both fully entitled to decide who's present for a very sensitive exam, but also has this history of intimate partner violence that may have made her even more uncomfortable with a male student being present than the average patient. And she may feel differently. We don't know the gender of the nurse midwifery student, but she may feel differently about that student being involved. So I think those are things I like to talk to students about, both how do we deal with bias when we're facing it, but also how do we respect patients and sort of their sensitivities, who they might want to be in the room or not be in the room, and how can students still learn a lot even if they're asked to not be in the exam room. Any other thoughts on what you would want them to take away from this encounter? Or how you might involve a student who's been asked to leave the room in the learning, even if they can't actually be directly involved in the patient's care. This is another one where I think debriefing afterwards is particularly important. And there are times when individually debriefing learners may be the best way to do it so that they can share some of their, feel comfortable sharing some of their personal reactions to the case. Okay, last one. So Miss West is a 73-year-old woman who was admitted to the hospital for a AAA, and she's currently stable but needs a procedure to repair it. When the inpatient team enters the room, her mother, brother, and 3 adult children are all present. Before the team can say much, they start to interrupt with questions. They want to know how many of the procedures the attending has performed, whether trainees will be in the operating room and what they'll be doing. One son says he did a search of about AAA repairs and wants to know why endoscopic repair is not recommended, so why this technique and not that technique. Her younger son asks, could my mom die? And as the team tries to respond to all of these questions, her mom starts to look increasingly distressed. And she finally says that she's 94, and in her day, it was not uncommon for residents to be allowed to operate unsupervised on poor Black patients like her family. So there's lots of trainees, sort of typical morning rounds, there's lots of trainees present, a surgical resident, a med student on a clerkship, and a PA student. What do you want them to take away from this encounter? And I will say that this is the only case that actually evolved from an experience that I had. So that I was the student in this encounter, and originally developed to use it with my first year med students to talk about how we respond when families bring up racism like this. Christiana said that medical distrust exists based on a lot of troubled history. Yeah, so this is I think this is a wonderful time to bring up the history of medicine. And talk about, you're certainly not going to cover all of it, but talk a little bit about it on rounds. Maybe ask a student to bring in a paper or do a short presentation or talk about some of this legacy of racism and experimentation that the patient's mom is bringing up and asking about. Any tools or techniques that you might use with learners? I think that this is also one where I really like the test framework to try to feel out what students already know, what learners already know, and what their gaps are. Have they had any training in how to talk to families in situations like this, or talk to families who are expressing mistrust? Or is a communication skill something we really need to work on right now? I think it's also one to think about making sure we keep the learners engaged, but a lot of learners in a situation where mistrust is already high and people are concerned about who's going to be in the operating room and who's actually performing procedures on that family. That's not necessarily a situation where everyone in a circle standing looking down at the patient is a good approach. So I think I would also talk with learners about how we come in. Do we come in and sit down and get on the same level with patients, which is so often what we're taught, but maybe not always what people see happening. And one more comment, I would hope this would bring insight into the unfortunate history of racism within the medical system, and experiences like these happened on people who are still living today. Any other comments on any of these cases? Okay, so I'm going to wrap up there for questions. I hope this has generated some insights and thinking about how we teach. I've certainly learned from your comments, and I'm happy to take any other questions now. And briefly, so this is the team who worked on the study. I just want to acknowledge all of them for their hard work in doing the interviews and focus groups and analyzing our data and helping me put together this presentation.
While we're wrapping up, I'm gonna drop the evaluation in the chat box for everyone to complete. But we'll stay on for more questions too.
Oh, and these are the citations for the cases if anyone's interested, because we published them for medical students and then readapted them for educators. And references. Okay, I'm going to stop sharing my screen, but happy to take more questions.
It looks like we have one question. When we discuss teaching models, is it useful to separate inpatient from outpatient settings?
Yeah, I think it is, in the sense that your ability to follow up and continuity is going to be different. Not that you may have some continuity in both settings, but the timeline is going to be different. It's much easier with an inpatient, or like the case where we had the patient coming in for chemotherapy who was all day on a Saturday, for me to ask a learner to, say, go back after she had gotten settled and spend some time talking to her about her current housing situation and the resources she'd already been connected with and how those were working for her. Where if it had been a short 15 or 20-minute visit in the clinic, and in a busy clinic day, it's going to be much harder to incorporate those things in the same way. And if your institutions are like ours, some clinics, the student may only be there for a day. Especially if it's a first-year student in our practice of medicine course, they drop in and out of clinics at different times. So there may not be another touch point between that educator and that learner to follow up. All the teaching may need to happen in the space of that busy clinic day. Now, if the learner is going to be there regularly over time, if it's a longitudinal clerkship, then there's lots of different opportunities for asking them to research something and come back and present on it, or tie it together, or have them see the same socially complex patient over time. So I think that's going to change how you approach the learning situations. Any thoughts on best practices in faculty development to increase instructor comfort and competence with challenging conversations around race and healthcare? I think the best approach I have found is to practice a lot. So I teach a first-year class that is from which these cases were drawn, that is a case-based discussion. It's called Patients to Populations. So we talk about ethics, public health, racism, equity, all forms of structural oppression, a really broad class. Most of our faculty are very experienced small group facilitators, so they have some of the uncomfortable conversations, necessarily the race and racism training. And what we are finding is that they fall into some of the classic pitfalls. A student will bring up racism and they'll move on or gloss over it or change the subject, but not dive into the uncomfortable space of talking about it. So what we've been doing is having faculty development sessions where we get together as faculty and have those. And I'm slowly finding that with lots of practice and awareness, that gets better. And with lots of reassurance that you will get it wrong, but only by getting it wrong and apologizing for our mistakes can we move forward. And then the other thing that we are finding is helpful. We have a nice cohort of really excellent observers with actually really great ethnographic observation skills, who we send to small groups to observe our faculty and give them one-on-one feedback on how they're doing with these things. And it's not part of formal course evaluations. It's not going on anyone's record, but it's really about giving the faculty member feedback and helping to call attention to things like, when that student brought up race, you really moved right on. We also had a group of students who reached out and said, we really feel like the men in our group are being allowed to talk over us. So we did some structured observations around that. And we found that the groups that didn't use hand raising were the groups in which not just women, but also learners of color, men of color, were much more likely to be spoken over. And I think there are lots of interesting cultural reasons why our white male students tended to feel more comfortable just speaking up without raising a hand. But what we did was implement hand raising across the board, and that really helped. Which I'm getting on a little bit of a tangent, but I think it goes to show, I think bringing in observers to your classes to see how your instructors are doing this and then give them individualized feedback is really helpful too. And the next thing I hope to do is to run a version of our med student course for a group of faculty who are not already comfortable having these conversations, who aren't already teaching in the course, but who are interested in practicing, and give them some opportunities to be learners before we ask them to be educators on these topics. I think as with the teaching at the bedside, it's hard when you don't have models of your own. If you didn't have classes like this as a health profession student, if you never saw bedside teaching, trying to figure out how to replicate that in our profession, which is very much based around see one, do one, teach one, is really difficult.
I was going to ask if you will allow faculty from other institutions, because then I will sign up for that class.
Oh, if we did an online version, that would be really cool. Yeah, I mean, I would for next fall that we might be back in person, but I really like the idea of a Zoom class. That would be, I would probably learn a lot from people joining from other institutions too. I will definitely, if we pursue that, I will let you know.
Thank you. I had a slightly different question. So my focus is a little bit more on communication and working with med students, working with residents, working with fellows. And I wonder what your experience is with the amount of sort of ingrained habit that occurs as folks go through their medical education, and how maybe a little bit harder it is to sort of move that needle in their clinical practice over time.
Yeah, I work, my bias is tilted towards med students because I spend most of my time with med students. And we don't have pediatric oncology fellows, so I almost never see fellows. But yeah, I think you're spot on to say if we don't expect this from the beginning, it becomes much harder to incorporate later on when people have sort of their own flow and their own routine and their, oh, here's how I do a history. It's much easier to start early. But that said, I think anybody at any point in training can learn or can have sort of, certainly I would like to say that I was good at addressing SDH in my practice, but until several years ago when I had that case I talked about, I hadn't really had an aha moment where I thought, oh, I'm not saying out loud all of this sort of conversation I have with myself in my head about providing good care. I'm not saying that out loud to learners, and I've tried to really change my practice and my approach to learners since then. So I think it's never too late. Okay, thank you so much for an interesting conversation and for engaging in the chat.
Yeah, thank you, everyone. Thank you to Dr. Brown for your amazing webinar and for everyone joining. I will follow up with everyone, like I said, in a few days with the recording. And it will also be posted on our website and shared on our Twitter if you don't already follow us. But yes, thank you so much.
Awesome. Thanks again, Dr. Brown. If it's okay with you, I was going to reach out and kind of have a follow-up conversation, because there's a couple of extra questions, I guess. But I want to...
I would be happy to.
Thank you so much.
This was awesome.
Just
please
wonderful.
email me. I'll put my email in the chat in case anyone doesn't have it.
Thank you. Thanks a lot.
I was going to say, for me, after doing this for 40 years, I'm loving how much I learned from you. So thank you.
Thank you for coming. I learned a lot from you too. Bye, everyone.
Bye.